our first speaker, who is going to occupy the stage for 1 hour. The first speaker is Dr. Francis Xavier Odida. Dr. Odida is our son from Uganda, but now lives in West Yorkshire, here in United Kingdom. Dr. Odida qualified from Dar es Salaam in Tanzania in 1980. But he did his internship in Mulago Hospital in Kampala, Uganda. And he actually practiced in Lira District Hospital until 1985. Dr. Odida obtained his master's degrees in obstetric and gynecology from Makerere University in 1989. He came to United Kingdom and obtained membership of the Royal College of Obstetric and Gynecology in 1996, and subsequently became a fellow of the Royal College of Obstetric and Gynecology in 2009. Dr. Odida practices in West Yorkshire with Airedale National Health Service Foundation Trust. He also teaches and examines medical students at the University of Leeds. Dr. Odida is a member of the British Society of the Gynecological Endoscopy, and is also a member of the British Society of Colposcopy and Cervical Pathology. Dr. Odida will talk about raised blood pressure and diabetes mellitus in pregnancy under this surrounding of COVID-19. Ladies and gentlemen, Dr. Francis Odida, our first speaker.
Thank you very much, moderator. Good introduction. I don't need to add any more. I have noticed that both hypertension and diabetes had previously been discussed in this forum, but I suppose that those were in general terms, and you have tasked me to now see what impact these two common diseases have in pregnancy during this COVID period. Let me share this screen. So the first topic that we are going to discuss today is high blood pressure. With the emergence of COVID-19 in early or late 2019 and early 2020, there was a lot of concern which was raised about its possible impact amongst pregnant women. That prompted an immediate inquiry by an organization called Embrace, which normally records all maternal deaths in the UK, and does so, brings up a report every 3 years. Now, they had to launch a rapid inquiry, and a rapid report was issued to see what impact COVID-19 was having on pregnant women. Their rapid report examined women between the 1st of March 2020 and the 31st of May. And in that report, 7 deaths were recorded by Embrace. Of the 10, 7 deaths were directly related to COVID-19. 3 of those deaths were non-COVID related, and the majority of the patients who died actually succumbed due to respiratory complications, and 1 as a result of cerebral thrombosis. All the deaths that were recorded were recorded after these women had given birth, so this was postnatal. The most striking thing for this report is that the BAME community seemed to have constituted the overwhelming majority. If we compare the Embrace report of 2019, which had gathered information about pregnant women for the year 2015 to 2017. They examined the deaths of 2,002,080,451 women who gave birth in the UK. And 2,009 women died due to complications of pregnancy-related problems. 5 of these women died of preeclampsia, which is, of course, the variant of hypertension that we are going to discuss this afternoon. Another body called the UK, which is the United Kingdom Obstetrics Surveillance Study, was tasked to actually record all information about women. And they did a similar but smaller study, but that looked at the deaths of 427 pregnant women who were admitted with COVID. And this survey was done in all 194 UK hospitals. And so 4.9 pregnant women per 1,000 died of COVID-19. 5 deaths were again recorded, and 55% were again reported as being of the BAME community. As you can see from the previous slide, this figure of 55 seemed to have gone down a little, but this is because more women were recorded in this report. The report further highlighted the fact that overweight and obesity played an important part, and that most of the women who died had severe disease, mainly in the 3rd trimester. They also found out that amongst those women who died, there was pre-existing high blood pressure and diabetes, which are the subject of our discussion today. So as you can see, high blood pressure is featured quite heavily, and as well as diabetes. Obesity and overweight is another comorbidity factor. Pregnancy itself has been thought to be a risk factor for women having severe disease through COVID. Now, the highest risk of severe disease seemed to happen during the 3rd trimester. So high blood pressure in pregnancy, hypertension, this is a common condition, and we know that it constitutes almost 10 to 15% of all cases. Preeclampsia, which is a variant of hypertension, which we are going to see in more detail, affects more or less 3 to 5% of all pregnancies. And eclampsia itself, which is the severest form of hypertension in pregnancy, complicates about 0.3% of pregnancies. This figure is certainly higher, certainly in Africa, and it remains the commonest or the common direct cause of maternal death. And in the last report of Embrace, it was the 9th cause of direct maternal death. So hypertension was discussed before, but before we go into the details, I would like to remind you of some basic changes which happen in normal pregnancy, which may affect the way we measure our blood pressure. As you can see from this graph, as early on in pregnancy, the systolic blood pressure, the blood pressure starts to fall, and this fall continues until mid-pregnancy. Conventionally, pregnancy is divided into trimesters, and the first trimester is about 13 weeks, the second trimester is another 13 weeks, and the third trimester is usually from about 26, 27 up to 40 weeks. What you can see from this diagram is that the mean arterial pressure decreases, and that decrease dips at about 20 weeks. From there on, maternal blood pressure then starts to rise and go back to normal. The reason why this happens is because in pregnancy, there's normal cardiovascular changes, which are adaptation for the pregnancy itself. There is a dilatation, peripheral dilatation of the blood vessels. Now, this change is brought about by progesterone, estrogen, and relaxin, and this tends to relax the blood vessels, hence the drop in resistance, and hence the drop in the blood pressure. The average drop in the blood pressures between 5 and 10 millimeters of mercury. Now, hypertension has been discussed before, and I'm not going to go into the details of its description, but in pregnancy terms, we classify it as being mild when the systolic blood pressure is between 140 and 149, and the diastolic pressure is 90 to 99. It is moderate hypertension if the the systolic is 150. If the systolic is 150 to 159, and the diastolic is 100 over 109 millimeters of mercury, it becomes severe hypertension if the systolic is at least 160 millimeters of mercury. Please note that in pregnancy, particularly in the second trimester, the gravid uterus, or the pregnancy, is now beginning to occupy the abdomen. Along this way, there are two major blood vessels, that is the inferior vena cava and the aorta, so that when a woman is having the blood pressure taken, that should be, the woman has got to rely onto the lateral side, which either left or right, at least about 15 to 30 degrees. And the types of hypertension that we encounter during pregnancy are pre-existing hypertension. Now, this is in women who have already had hypertension prior to becoming pregnant, and they've been known to have hypertension, and they could equally be having treatment with various medications. The second type of hypertension is that described as pregnancy-induced hypertension. This is so because this hypertension is discovered for the first time during pregnancy. And the third type is preeclampsia, which is now not only the hypertension or the raised blood pressure, but there is the presence of protein in the urine. With regards to pre-existing hypertension or the chronic hypertension, as I've said before, these patients are normally known already as having hypertension. But pre-existing hypertension are often discovered when a woman has had hypertension for the first time in pregnancy, but then gives birth and the hypertension persists for more than 3 to 6 months. Such hypertension poses the risk for superimposed preeclampsia and the risk of the pregnancies being complicated by small babies and an abruption placenta. So if any woman who has got pre-existing hypertension in considering a pregnancy, then it is advisable that the woman is seen at a preconception clinic. This can be either the gynae clinic or by a GP. At that clinic, all our medication needs to be reviewed because some of the medications that are used for controlling high blood pressure may not be indicated during pregnancy. At the pre-conception clinic, women are also advised about starting to take folic acid, aspirin, and vitamin D, and we are going to touch onto these useful medications as we go along. These patients with pre-existing hypertension also need to book early. As soon as they find that they're pregnant, they need to report and book themselves for antenatal care. At that point, their blood pressure, the urine, and other blood tests are taken. Due to COVID, however, some of these consultations are now being done virtually, and that is to reduce any risk of acquiring COVID. But in all, most pregnant women are seen between 10 and 14 weeks when they've had a dating scan. The women are also encouraged, if possible, to avoid contact with either healthcare people and reduce the risk of COVID by self-monitoring their own blood pressures. The second variant of pregnancy hypertension is that which is called gestational. This is pregnancy-induced, and it is usually found for the first time in pregnancy. It happens usually around the second trimester. There is no protein in the urine, and this kind of hypertension normally tends to resolve as soon as the woman has given birth. The way it is diagnosed is that if a woman presents with a blood pressure of 140 degrees over 90 millimeters of mercury, repeated after 30 minutes, and it is still persisting, then that is pregnancy-induced hypertension. There is no proteinuria. It can also, the diagnosis can also be made when there is a single measurement of a diastolic of 110 millimeters of mercury. Because of the drop of blood pressure that we have seen previously, it is quite often that a woman starts on with a very low blood pressure. And therefore it is conventional to try and look back at the booking blood pressure and add 30 millimeters of mercury to the booking blood pressure to see whether that level justifies the diagnosis of preeclampsia, because a woman could have a blood pressure of 135 millimeters over 85 and still be hypertensive in terms of the pregnancy-induced hypertension. As I said, it normally starts in the sooner after 20 weeks. The control of their blood pressure should start if this blood pressure persists at 140 over 90 millimeters of mercury. Regular blood tests are required, and this should be done very frequently. A place where it is done can be at either the midwife or the GP, or indeed hospital appointment. Some women could be provided with their own home blood pressure machines which have been validated to take correct blood pressures. Regular scans would be required to monitor the fetal growth, and of course, a period and a time for when delivery should take place. Preeclampsia is a pregnancy-specific kind of hypertension. It also occurs after 20 weeks of pregnancy, but more so around 24 to 26 weeks. And it is thought to be a placental disease. It affects the lining of blood vessels all over the body, and is often described as being multisystemic. It is variable and unpredictable. Again, the diagnosis would be based on a blood pressure measurement of 140 over 90, which has been taken at least on 2 occasions, 30 minutes apart, or a single measurement of 110 millimeters of mercury diastolic. There is normally protein in the urine, but the presence of protein in the urine, which is detected by ordinary dipstick, is unreliable. So if the dipstick is positive for protein, then one needs to do a 24-hour urine collection to quantify the actual amount of protein. So the classic signs, of course, of preeclampsia is high blood pressure, proteinuria, and occasionally edema. So who is likely to get preeclampsia? Preeclampsia is common amongst women in their first pregnancy. It is also common or can be found in people who have had a preeclampsia in the past. It is also found in women who could have chronic hypertension and then develop proteinuria. There is normally a history of preeclampsia, and indeed diabetes has been implicated in preeclampsia. Women who are overweight or obese, and obesity is a body mass index of more than 30 kilograms per square meter of height. Women carrying multiple pregnancies also run the risk of developing preeclampsia. And it is thought that extremes of ages, teenagers, for example, teenage girls at risk of developing preeclampsia, as well as women who are delaying childbirth. This could be because of career progressions and so forth. Women who have got kidney disease are also at risk of developing preeclampsia, and it is possible that the kidney disease is a factor in producing protein in the urine. Pregnancy intervals of more than 10 years is also associated with the risk of developing preeclampsia. Now, the complications of preeclampsia in severe cases is that this could lead into brain hemorrhage. The placenta would separate in a condition called an abruption, and they could subsequently then develop the more severe form, which is eclampsia, which we are going to touch on shortly. Severe preeclampsia also leads to a condition called HELLP syndrome. Now, the HELLP syndrome simply means destruction of red blood cells, hemolysis, and because of its effect in the liver enzymes will be raised, and it also destroys the platelets, which are important for clotting. In addition to that, a lot of the clotting factors in the blood are consumed as a process, and therefore, should there be any bleeding for whatever reason, these patients bleed very severely. The severe preeclampsia also complicates the kidney in that there could be acute kidney injury, which is that some parts of the kidney would be damaged. Because of leakages from these abnormal blood vessels, edema or fluids tend to fill in the lungs, and we get pulmonary edema. And that in itself can lead to acute respiratory distress. Preeclampsia itself predisposes to babies being small in growth, and that is because of the dysfunction of the placenta. As we said, it is a placental disease, and this placenta is probably not functioning well, so the babies tend to be small. There are often lack of the amniotic fluid, which is the fluid around the baby during pregnancy, a condition called oligohydramnios. Because of the non-functioning of the placenta not functioning properly, the babies tend to have some kind of oxygen starvation. Which then results into fetal distress. And as we said previously, there is always the risk of the placenta separating. And in severe cases of preeclampsia, there is preterm delivery, but this is because the treatment of preeclampsia is delivery. And if the hypertension is not controlled by conventional means, women are delivered prematurely. The symptoms of and the signs of preeclampsia include headaches, and most of these people complain of flashing lights. These headaches is a result of irritation of the brain. There is also epigastric pain. Now, the epigastric pain is a result of inflammation of the liver, and particularly the liver capsule. There is, of course, protein in the urine, as we have said, and these ladies will present with swellings involving the face, the fingers, or the legs. And their pregnancies also tend to be complicated by small for growth, abruption, and sometimes unexplained death in utero. Monitoring of preeclampsia requires, of course, that the blood pressure be checked quite regularly. And it also requires regular blood checks to determine whether the kidneys are functioning well, whether the clotting systems are okay, and also how the liver is functioning. Regular urine tests are required, and Doppler ultrasounds scans are normally used to examine the blood flow from the vessels in the uterus. So it is called a uterine artery Doppler. This is carried out around about 20 to 24 weeks, and it gives a specific feature which is called notching. But of course, these ladies would need fetal surveillance using growth scan, and this is normally done sequentially from 28 weeks, 32 weeks, 36 weeks, and so on. So when and how is it to treat the hypertension? You consider treating hypertension when the blood pressure is more than 140 over 90 millimeters of mercury. This sometimes might require that these ladies be admitted first in the hospital because of the uncertainty of their response to the medication, and that is mainly just for stabilization. The management of the hypertension should not be overzealous, because if we drop the blood pressure very quickly, there is the risk that that would reduce blood flow to the uterus and the placenta. But overall, the aim of treating this hypertension is to maintain what is known as the mean arterial pressure of 125 millimeters of mercury. That is a clever way of calculating that, and sometimes this is done automatically by the automated blood pressure machines. The drugs that are commonly used for hypertension in pregnancy include things like labetalol or nifedipine. This is going to be dealt with by one of our panelists, the pharmacist, will enlighten us more on that. In severe cases of preeclampsia, where these patients are likely to develop eclampsia itself, then sometimes it is prudent to preempt and protect eclampsia, and such women are normally admitted and treated with magnesium sulfate. The timing of delivery, of course, preeclampsia itself is a placental disease, and it can only be cured by delivery. That can sometimes be determined if there is any deterioration in the blood pressure or problem with the fetus. Delivery is normally carried out after the blood pressure has been controlled adequately. And if severe, magnesium sulfate may be required. And in some cases where there is prematurity, when the blood pressure is so severe before 34 weeks of pregnancy, then administration of corticosteroid called dexamethasone, which is to promote lungs in the babies before delivery. So the delay in delivering a woman with preeclampsia is merely to buy more time, increase fetal maturity, so that when the baby is born, the complication of prematurity is lessened. But overall, once preeclampsia has been diagnosed, delivery is normally within 2 weeks. There is, of course, a high cesarean section rate because of prematurity and severity. The recommended drugs which we commonly use are labetalol. Sorry, my presentation keeps going back, but labetalol, which is alpha beta blocker, is the first line of treatment. Second line of treatment is nifedipine and then methyl-dopa and hydralazine. I think the pharmacist was going to talk, or is going to talk about these particular drugs at the end of the first part of the presentation. So the last part of type of hypertension is that of eclampsia. Now, eclampsia is a very serious life-threatening condition, which normally presents with maternal fits. These ladies start convulsing profusely. It is thought that it can happen before a woman goes into labor in about 45% of cases. In 18 to 19% of cases, this fit can happen during labor itself. In 36% of cases, eclampsia would be experienced after giving birth. And it is found that 5 to 30% of these episodes would occur whether or not the patient has been on treatment. It is far more common in teenage mothers, and it can easily produce a stroke or eye condition called cortical blindness. The management of eclampsia itself is an emergency. In hospital-based management, there is a protocol which is well established in most of the units. Drills are conducted regularly to make sure that if a woman goes into an eclamptic fit, the management is urgent and it is multidisciplinary. That would involve urgent call for help using the appropriate emergency calls and initiating basic life support in the case of airways, breathing, and circulation. The control of these fits is normally by magnesium sulfate. We don't use any other type of anticonvulsants in this country. So magnesium sulfate is normally given as a bolus to begin with, and then a maintenance dose, which runs for 24 hours. If there is any further seizures while the woman is being treated, additional magnesium sulfate can be given. The aim is to control this blood pressure so that it is at least below 150 millimeters of mercury. If the blood pressure itself is not responding very well with oral medication, then intravenous labetalol, or indeed sometimes hydralazine, may be required. And the management of these ladies require that we strictly restrict their fluids, because, as we said, in severe preeclampsia, there is a lot of edema. Most of the fluid is actually into the tissues. And the more fluid that a woman is given, the more that there's a risk of fluid overload and pulmonary edema. And of course, most of the vital signs are monitored very closely. These ladies need to be delivered as soon as the condition is stable, and delivery is normally by cesarean section, as that is the easiest and the quickest way. So I think at this stage, I might just ask Peace to talk through the antihypertensive medications. Is that all right?
Yes, that's fine. Okay. I'm just going to briefly share the screen. Is that okay?
Yes, you can proceed. I mean, please, yeah.
Thank you.
Yeah. Now you
let me unshare.
Yeah, you should stop sharing. Yes, yeah. Francis, if you can stop sharing.
Yes, I have.
Yeah. Then please can share, and then you go through the medication quickly.
Yeah. Mm-hmm.
Jasper, I hope you are compiling some questions for us.
Are we seeing this clearly?
Go to slideshow.
Yeah, Thank you, Dr. Francis, for the very detailed information. And just to pick up from where we've left off, so far we've covered the high blood pressure in pregnancy. So I'll go ahead with that. So essentially what you've covered does resonate really with the guiding principles of what they look at. With the medications that we briefly touched on, any practicing doctor or anyone in a multidisciplinary overview of a pregnant woman, they need to weigh out the risk benefit, and the assessment of that against the medicines. Is the medicine both safe for woman, for the mother and the baby? Also, we work on the basis of all medicines, they do cross the barrier. This is something called the placental barrier. It's the link between the mom and the baby. So it's safe to assume that all medicines do cross this barrier, but how much they cross is what determines which medicine they do recommend. And I think we mentioned as well already, the first trimester, the first 3 months is when it's most crucial. And that is because the baby's developing and the organs are forming. So the medicine needs to be as safe as possible in this section. And then, yeah, if we don't get it right, these are the further complications that we look to avoid, predominantly unplanned or unexpected miscarriage, congenital malformations. This, in simplest terms, it's the birth defects that can happen when a baby is developing. So those could be things like cleft palate, neural tube defects. These are things that could happen during the pregnancy, but some can be as late as after pregnancy, hearing loss. So without further ado, I'll continue. So when we are now looking at chronic hypertension in pregnancy, as we do mention, the first line is labetalol. This is something that would be based on the safety profile in a pregnant woman with chronic hypertension, chronic meaning sustained high blood pressure in pregnancy. Labetalol is the first option. If for whatever reason this is not suitable for pregnant women, most cases could be in asthma, for example, that's when nifedipine is given. As far as you need to know, what the take-home message is, nifedipine is the second option that can be given if the first option isn't working. Now consider in some people, option 1 is not working, option 2 is not suitable, then there is a third option called the methyl dopa, which is another case that can be given. But before any of these medicines are even started, they need to look at pre-existing treatments. Some women would be pregnant already before having the baby. Can these medicines be continued whilst they're pregnant? Sometimes yes, sometimes no. Then that can be stopped. Classic examples are medicine called ramipril, for example, and then they look at the side effect profiles of how much is this medicine going to affect the mom. Is it worthwhile continuing with that? But then also the bigger priority is always, is this going to affect the baby's development? And lastly, we work on a basis of mom needs to be informed with these options, and both the mother and practitioner come to an agreement called informed consent. So in chronic hypertension in pregnancy, the aim is always to control the blood pressure. And in science terms, controlling the blood pressure is systolic at about 135 millimeters of mercury and diastolic of 85. But the key take-home message when a mom comes in is nervous, unsure of whether this is the right medicine, there's always enough clinical evidence to support the use of this medicine. But from before pregnancy, during, and even after, there needs to be close medical supervision, all the while working to reduce the possibility of fetal complications. And any woman that has, any chronic hypertension, aspirin is always part of this group of medicines that are given, taken once daily. And this is normally given from 12 weeks. 12 weeks because we've gone through the first crucial 3 months of pregnancy, then anything from 12 weeks onwards. I won't go into it further. We've already discussed the use of magnesium sulfate in preeclampsia, or even in eclampsia, the most serious forms of blood pressure in pregnancy. So I'll hand over back to Dr. Francis for now. Thank you.
Okay, thank you, Peace. So the second part of the presentation is diabetes in pregnancy. Again, this is a topic which had been adequately covered previously in this forum, and I'm just going to talk through how it impacts on pregnancy. Normally, when we eat any food, the food that we eat is converted into glucose, and the glucose that has been liberated is absorbed and goes into the circulation and distributed to the rest of the body. Now, there is a gland called the pancreas, which is located just below the stomach, and that gland is important in producing insulin, which is an hormone. Now, the insulin is important because it does promote the entry of glucose into the cells, and this glucose is then utilized by the individual cells to produce energy. And I will not go into details of the actual processes, but it requires oxygen and the release of carbon dioxide and so forth. In diabetes, there is a lack of insulin, or it cannot be used. And so what diabetics experience is that there's a lot of glucose around, and they're unable to utilize it. So it is a state of starvation with plenty of food around. So the other thing is pregnancy itself diabetic? It does appear so because during pregnancy and very early on, as early as about 8 weeks, the placenta, which is forming, starts to produce anti-insulin hormones. And those hormones, like the human placental lactogen, glucagon, which is almost like a medication that diabetics use to boost up their glucose level when the glucose drops due to treatment, and cortisol. Those brings about a rise in blood sugar in the circulation. It is noted that in pregnancy, insulin itself, the production goes up, but there is a resistance to insulin. So the insulin which is there is actually not functioning. So we are in a state of glucose intolerance. The kidney becomes overwhelmed because of the glucose in the blood, and there is a tendency for then this spills over into the urine. The diagnosis of diabetes in pregnancy is normally made when a woman presents with passing a lot of urine, feeling thirsty, and indeed occasionally weight loss. The dipsticks can be used to test the urine, but this is unreliable. The real diagnosis of diabetes in pregnancy is when a blood test is performed and gives the concentration of glucose in the blood of more than 11.1 millimoles per liter. Or if this blood test is done fasting, that is when one has not had anything to eat or drink for at least more than 6 hours, then if the level is more than 7, then one would assume that there is diabetes. But the standard, the gold test for diabetes is that which is the oral glucose tolerance test, where one is given 75 grams of glucose, and then a series of blood tests are measured. At the end of the 2 hours, if the sugar level is more than 11, then that confirms diabetes. There is also another variant of diabetes, which is impaired glucose tolerance. Now that the blood glucose can still be less than 7 after the oral glucose tolerance test after 2 hours, but it will be less than 11. In diabetes, we tend to classify this into pre-existing diabetes, which is diabetes which is present before pregnancy, and gestational diabetes, which is that diabetes which is linked to the pregnancy itself. The pre-existing diabetes is type 1 diabetes. Now, it is called juvenile because it is present in mainly young people. And in this type of diabetes, insulin is not produced at all. And this patient would almost certainly rely on insulin entirely for managing that diabetes. But in the pre-existing diabetes patients, falls also the type 2 diabetes, which is, this is non-insulin, and it is also called maturity onset because it tends to develop later in life. The gestational diabetes, again, is divided into 2, which is true gestational diabetes, which is the diabetes which is detected for the first time. But there is also pre-existing. Now, it sounds a bit controversial to have pre-existing diabetes being called gestational diabetes. This diagnosis is normally made retrospectively when somebody has been unaware of diabetes or it has not been detected during the pregnancy, but then discovered afterwards. So pre-existing diabetes appears to affect 0.5% of all pregnancies, while the type 2 affects probably 3 to 4%. The incidence seems to be much higher in Asian and Afro-Caribbean, that is about 10%. But overall, in all pregnancies, it probably affects about 0 to 4% of women. So the type 1 diabetes, that is the one which relies entirely on insulin because there is no endogenous insulin. It affects mainly young people, as we have said, and it appears as if it is mainly affects people of European heritage. And this diabetes also seems to be linked to autoimmunity. And I think viral infections seem to be implicated in that instead of the antibodies fighting the virus, the antibodies are then directed to the pancreatic tissue. And it is organ specific, and also it can be genetic or inherited. Type 2 diabetes, however, is normally a disease of the much older women. It is also associated with people who are overweight or obese. And again, we find that the Asian, Afro-Caribbean, and Middle Eastern heritage seem to be more affected. It is thought that type 2 diabetes is becoming more and more as the population becomes overweight. The incidence seems to be going higher. People with type 2 diabetes normally have this symptom long-standing, but they may also require insulin for that treatment. So how is pregnancy then affected? How might pregnancy itself affect diabetes? For those who have type 1 diabetes, becoming pregnant will push their need for insulin up, because pregnancy is thought to be diabetogenic, as we have mentioned before. In those who have got type 2 diabetes, even though they may be usually on treatment with oral anti-diabetic medication, they may need supplementary insulin, particularly in the 3rd trimester. How about the babies? How are the babies affected by diabetes? There is a risk of congenital malformation, and this is particularly when the diabetes has not been well controlled, and the abnormalities that are found associated with poorly controlled diabetes is that of spina bifida, which is a neurotubular defect. There are also all sorts of cardiac abnormalities. The specific abnormality which is associated with diabetes is what they call sacral agenesis, where there is a defect of the sacral bones. The diabetic babies normally would, their pregnancy would be complicated by a lot of fluid around the baby, a condition, and it is thought that this excess of fluid is because the baby passes quite a lot of urine, and that adds into the normal amniotic fluid. Because of that, there is a tendency for labor going prematurely. Babies of diabetic mothers also tend to be bigger, and the diagnosis of big babies that is presenting with macrosomia is made when the estimated weight of the baby is more than 4.5 kilograms at birth. And that poses problems, particularly when it comes to childbirth, in that the labor can be complicated by a condition called shoulder dystocia, which is difficulty in delivering the shoulders. Again, there has been incidences of unexplained fetal death, and it is thought that these babies tend to die in utero because of a lack of oxygen exchange at the placenta. In diabetic mothers tend to have rather swollen placentas, which function very poorly, and the exchange of oxygen is not adequate, and therefore these babies tend to starve and sometimes do die in utero. When these babies are born, they tend to develop very low blood sugar, and the reason is that maternal insulin normally passes through to the baby, including, of course, the glucose. And once the umbilical cord has been clamped, there is no more supply of glucose, but there's an excess of insulin, and that drives the hypoglycemia in babies. How about the mother? The risks are again related to poorly controlled diabetes, and ladies whose diabetes have been poorly controlled experience recurrent miscarriage. They would also experience recurrent infection. This could be chest infection, bladder infection, and particularly thrush. If these women are already having the eye complication, which is called retinopathy, and these conditions seem to worsen with the diabetes. Again, if they've already got kidney problems like nephropathy, these also tend to be worsened with diabetes. And of course, we've just mentioned big babies. Traumatic delivery would be common when the babies are big. And when they're treated very aggressively with medication, there is a tendency for them to drop their blood sugar levels, producing hypos. Now, gestational diabetes, that is the one which is linked to pregnancy, is often described as carbohydrate intolerance. It is found for the first time during pregnancy, but as we have mentioned before, it also includes pre-existing diabetes, that is because the diabetes has not been recognized before pregnancy, but then develops after delivery. It is fairly common amongst white people, but again, we find that gestational diabetes is fairly common amongst the Black, Asian, and minority ethnic group. It will commonly present no later than the second and the third trimester of pregnancy, and usually without any symptoms whatsoever. The diagnosis is normally made because of a family history of gestational diabetes, or a woman who has had a light for gestational age and presenting with a high BMI and could have suffered gestational diabetes in the past. Again, we find that if somebody is of the BAME community, then there's a risk of developing diabetes. Screening is normally offered at around about 24 to 28 weeks gestation, and it is by the standard oral glucose tolerance test. Gestational diabetes sometimes is suspected because of this polyhydramnios, that is excessive fluid, and when the baby appears to be growing big, and so the scan will then prompt investigation of diabetes. At some time, it is made retrospectively after a woman has had a stillbirth with a big baby. The test results, of course, are the same as in any other diabetes. The mainstay of diabetes management is dietary control and regular exercise. Women with gestational diabetes normally do not require medication, but if diet and regular exercise do not help, then they might require additional treatment. Diabetic mothers should be managed very jointly. This is normally with the obstetrician, with the diabetologist. Dietitians are normally involved in their management, and it is thought that in doing so, their managing is optimized. They would need regular blood tests. This is normally achieved by home-based glucose monitors. These ladies would monitor their blood sugars regularly, and I think if the post-meal, that is the blood sugar which is tested after a meal, is more than 7.8 millimoles per liter, then they will require medical treatment. Metformin is the treatment of choice, and I think our pharmacists may talk about this later on. That is normally indicated if diet has failed. Insulin may be required in addition to metformin, but these are normally decided by the diabetic team, who normally look after them. Delivery is usually at term, particularly for gestational diabetics who are not on medication. But otherwise, if gestational diabetics are on medication, recommendation is that they should be delivered soon after 38 weeks, because most of the incidences of unexplained death in utero occurs around about that time, between 36 and between 36 and 38 weeks. The aim of managing diabetes in pregnancy, of course, that you need to achieve your normal blood glucose level, and you do that by doing frequent home-based glucose monitoring. The plan is to achieve the pre-prandial, or the level before a meal of 3.5 to 5.9 millimoles per liter, and a level of 7.9 after you had a meal. And it is thought that the level of glucose which is good after a meal correlate much better with the weight of the baby. Type 2 diabetes requiring treatment it is normally with metformin. There had in the past been controversy about metformin not being safe in pregnancy, but this has now been approved even by NICE, the National Institute of Clinical Excellence. Insulin may be required in addition to that. The obstetric management, as I already mentioned, requires that they should be seen jointly by specialist nurses, the specialist dietitians and nutritionists. These women need to book very early during pregnancy for viability, and also to be screened for any soft markers for congenital abnormalities. And this is normally done by ultrasound scan between 11 and 13 weeks. They would need a detailed ultrasound scan about 18 to 20 weeks, and subsequently to do serial scans from 28, 30 to 36 weeks to detect whether the babies are growing bigger and bigger. Again, folic acid, vitamin D, and aspirin are normally recommended for women with gestational diabetes. Delivery, again, is normally about 38 weeks. If there is an indication for an early delivery, then these ladies will normally require giving dexamethasone, and dexamethasone is a steroid which is useful for maturing the fetal lungs. The problem with diabetic is that when given this medication, then the blood sugar tends to go up. And in that case, women who are given corticosteroids are admitted and given insulin infusion sliding scale during the administration of corticosteroids. Pre-pregnancy, of course, is the hallmark of treatment that would facilitate good control with diabetes. The glycated hemoglobin, which was mentioned last time in the presentation of diabetes, is a marker, and it is thought that if it is normal, it also seems to indicate that there's a lower risk of preeclampsia. Preconception folic acid is recommended, as we have said, during the pre-pregnancy counseling. And again, low dose aspirin and vitamin D are often required. During labor, if a woman is not on any treatment, then labor is normally just as normal. But for type 2 diabetics who are on insulin, they normally require infusion of insulin during their pregnancy, and regular monitoring of their glucose during the pregnancy. So I'm not sure whether Peace is going to talk again about anti-diabetic medications.
Yes, I can do, Dr. Francis.
Okay.
Yeah, Peace, if you could just make a very brief comment on metformin.
Yes.
Okay, so let me stop share. I seem not to be able to stop share. Why?
Yeah, it should be somewhere. Yeah, that's it.
Have we done it?
No, you should, yeah, you should do that. Go.
Yep. So hopefully you can see the screen okay.
Yes, we can.
Perfect. So yeah, very briefly, I will follow on from what has been said, where we've covered the diabetes itself. So just briefly mentioning that, you know, even when they've given the medication itself, the key things are the assessments that are happening before, during, and after. And that's why it's very important that someone with pre-existing diabetes, there's a lot of planning and care that has to be happening in the future, throughout the pregnancy, let's say. And all in all, we're working towards good blood glucose control. And that good blood glucose control means regular testing of a pregnant woman through what we've mentioned with Dr. Francis, of blood glucose monitors that are given to the mothers to test their glycated hemoglobin, on a daily basis. And this happens in a frequency that is determined between the mum and the dietitian, and as well as anyone else involved in their care. So yeah, essentially we've covered it. Where we are in type 1 diabetes, this is the situations we mentioned where the body's unable to produce the insulin that is required, so they do need that insulin to be given itself, and this is first line recommended. They come in different forms. Some can be rapid acting in itself. These would be short acting, and and they're normally given on a twice daily or sometimes 3 times daily regimen. And then also they have to consider a long-acting insulin. These regimens are normally given to just insist on this better control of their blood glucose levels. Long-acting examples are there. These insulins can sometimes come from human insulin or sometimes from animal, bovine, cow insulin if required. And this is all just to control the blood glucose, as we've mentioned. The key things in itself within type 1 diabetes is also just monitoring chemicals called ketones. This is where, imagine the body is unable to produce the energy or the sugar that it requires. It starts using other chemicals in the body. So that's why with pregnant women that are diabetic, it's very important to encourage them to monitor their blood glucose, but equally as well, this ketone, which is a chemical typically within the blood itself, but and the urine sometimes. But the blood glucose, the monitors that are given will help to monitor this. So that would be the situation there. Now, when we come to type 2 diabetes, which we've covered very well, can be purely controlled by the role of diet and exercise itself. But where a pregnant woman is concerned, this can have its own challenges in itself. And quite often the first line given is metformin. So metformin is the first line medicine recommended by NICE guidelines and generally in terms of understanding for pregnant women. It works in 3 ways really. One, it helps with decreasing how much the liver, which is an organ in the body, produces or stores glucose. And also it helps as well to increase the uptake of insulin being used for energy production in other organs as well. And lastly, just monitors the uptake of that. The metformin itself is normally first line, which is something given orally. So it's very practical and very easy for pregnant women to use. Of course, they have to consider the side effect profile, which sometimes can be GI or abdominal effects, which can be heavy on the stomach, but these tend to ease off, and that's why it's something that's relatively safe for women to take. But if metformin, which is first line, is not working, that's when they have to consider the options of metformin along with insulin itself, and these can be the quick acting and the long acting we've mentioned. Sometimes they can decide to abandon the metformin itself and stick with insulin just all the while to encourage better control. But the key thing with insulin or with diabetes is very good control, and we can have situations where...
Sorry, Abid, please, can you put it on slideshow, please, so that the screen is viewed?
Are we seeing it now?
Put it on a full slideshow.
Oh, I'm very sorry.
Better. Yeah, that's better.
Sorry, I wish I had known of it earlier. But just to continue from where I'd left off, we've covered the type 1 diabetes, and then with type 2, as I was mentioning itself, if metformin, which is the first line, is not working, that's when we have to consider metformin along with insulin, or sometimes the insulins that I've covered briefly are the main option given. All the while, along with diabetes, control is the key thing, and that's in the shape and form of the diabetic reviews we've covered, and along with the medicines reviews and the insulin regimens, if they're working, just to avoid any further complications or complications from the medicines itself. And that's why it's very important monitoring things like hyperglycemia. This is a situation where the blood glucose, we've controlled it even further than where we intended, and now we're giving the pregnant mom complications. But also in certain situations as well, we want to avoid this issue of too low, which is hyperglycemia, or too high, which is hyperglycemia, and avoid the mom being unwell. But it's also safe to mention, as part of a complete medicine package, such women, they are given the folic acid, I think we've mentioned, and they are in a situation where it's a higher dose folic acid that would be given for them. And this is something that is given until 12 weeks of pregnancy, all the while to reduce any further complications of the disease, but also to avoid any development complications of the baby. Thank you. So I'll hand over back to Dr. Francis.
Please, have you got anything on aspirin, folic acid, and?
Yes. Yes, I can do.
Yeah, because I was just going to mention it very briefly. So if you could just complete that would be lovely.
Sure. So yes, just to follow on from what we were saying, when a lady is pregnant, we have to consider where are they getting from their diet, their nutrition, and more importantly, their medicines that they're taking just to support their pregnancy. So all this is something that is discussed pre-pregnancy and during antenatal appointments. So aspirin is one of the, in a pregnant woman, aspirin is more likely than not going to be a medicine that is given for them. Aspirin is a medicine that works as an antiplatelet, which can help to thin the blood itself and avoid any further complications, but it also helps to protect the heart and avoid any cardiac or heart conditions in mother and in the baby in the future. So in a pregnant woman, aspirin, baby aspirin, which is a 75 milligram dose, tends to be the given. This can also sometimes go up to 150 milligrams, depending on the individual mother's situation on that risk-benefit analysis that we've mentioned before. Typically, enteric-coated one is given. Enteric-coated simply means it's a medicine that is going to protect the stomach and avoid causing any stomach disruptions or stomach irritations from the mom. And aspirin typically is given from the 12 weeks of pregnancy that we've mentioned. Also as well, where there's a possibility of complicated pregnancy, or where there's a woman that's a bit on the heavier side in terms of the BMI, the body mass index that's mentioned, from about 25 kilograms per meter squared, that's when it's given. Another very common medicine that is supposed to be started pre-conception when a woman is thinking of becoming pregnant and up until 12 weeks of pregnant is something called folic acid. This is the main medicine that is considered just to avoid any fetal or baby development issues that we covered briefly at the beginning, if you mentioned. So those would be the things like neural tube defects, spina bifida that we've mentioned. Sometimes these can be brain defects or spinal cord injuries or complications we've mentioned. If imagine that a woman that has had previous birthing issues, we know that they have diabetes or this high blood pressure, chronic blood pressure that we have covered before, that's when they would be actually recommended to have a higher dose of folic acid, which is the 5 milligrams. And this is something that is taken every day up until the 12 weeks of pregnancy, whether it's the low dose, the standard 400 microgram dose of folic acid, or the higher dose of the 5 milligram folic acid itself. But all the way throughout pregnancy, supplements and nutrients are very vital for both the mum and for the baby. And there are different formulations available, but we know that the Department of Health encourages mothers to continue with the folic acid without mention. Vitamin D also is another vitamin that historically was something pregnant women or people in general would have been using for maintaining their bones, for example, and it was something given in combination with calcium. But more and more research has come to support the use of vitamin D, as we've seen through the current climate we're going through with COVID, to support the immune system and protect the baby with that. And that's something that is recommended as part of a pregnancy package for a pregnant lady. So that is the iron supplements, the vitamin D. Vitamin C also as well is something that is given all the while to protect the immune system for both mom and baby. And there's different formulations available itself, but Pregnant Care is a well-renowned and licensed brand that can be bought from pharmacies, supermarkets. And this brand is special because it contains all the nutrients if it's a typical pregnancy. So the mom doesn't have to worry about anything else that they need to take. They just need to religiously take this medicine once a day. But of course, this is if it's a typical pregnancy. Where it's a bit of a complicated pregnancy, the healthcare practitioner will recommend to the mom which pack to take, and if they need to take anything further, like the high dose folic acid we've covered. Some women are very eager to go and get the multivitamins and along with other things, but we do advise them to be cautious because some vitamins, not all vitamins are as good as what we would think or encourage for pregnant women to be using. Vitamin A in particular, which is most commonly found in the liver, tends to be one that has to be used with caution. It's something that is already naturally produced in the body. But if someone was to take, if a pregnant lady was to take an additional vitamin A on top of anything in the multivitamins, this could actually cause developmental or complicated birth issues for the mum. And that's why it's very important that when a pregnant lady presents to a pharmacy or any healthcare setting, we are covering with them which nutrients or supplements are they taking in addition to what they are actually recommended for. So some women also would think, do I have to take medications itself? Yes, you can get some of these vitamins from your diet, green leafy vegetables, for example, certain oily foods, oily fish, for example. But again, you have to be very careful because the amount of these nutrients or supplements that you can get from food alone is sometimes more commonly not substantial. And that's why these additional supplements are recommended. And lastly, it's advising pregnant women to consider vaccines. Yes, controversial, where some might have their own personal opinions on whether a vaccine is going to be completely safe for them. But we know from the research that is already recurring, both from the Department of Health and the World Health Organization, vaccines such as the flu vaccination is definitely very worthwhile just for any stage of pregnancy to protect the mum and the baby, and also other vaccines like rubella as well in the future, very worthwhile to consider for a pregnant lady. So yeah, the take-home message is frequent testing, take the medications and supplements as required, and if there's any further complications of the hypertension and the and diabetes, there are first line, second line, and even third line medications that are required to complement a pregnant lady's medicines package. So thank you. Back to you, Dr. Francis.
Okay, thank you, Peace. Moderator, have we still got adequate time?
Just yeah, you can finish off your lecture and then we'll have time.
Okay. The next thing that I want to talk about is really the antenatal care recommendations during this COVID pandemic. The advice that has been given for healthcare professionals during this pandemic is that pregnant women have been identified already as being those who are at higher risk of severe disease if they should catch COVID. And that all pregnant women, or even those who have given birth, need to be looked very, very carefully in a kind of a multidisciplinary approach. So the experts need to assess their condition and severity of their disease early on, so as to optimize their care. During the COVID pandemic, it is important that access remains essential. It has got to be maintained, and that is access to antenatal care, access to maternity assessment clinics, access for ultrasound scans, access for blood tests. All those need to be performed, and particularly in women of the BAME background, and also for women who have got hypertension and diabetes. We know that, of course, hypertension and diabetes have been identified as giving severe risk of COVID infection. Pregnant women who are suspected with COVID, they need to have a low threshold for a multidisciplinary approach. So they need to report so that they're handled quickly and by experts. It is also recognized that pregnant women with suspected COVID, particularly if they're admitted to hospital where their mobility is going to be limited, they should receive blood thinning medication in the form of low molecular weight heparin. And they should also minimize, if as much as possible, any in-person contacts with the healthcare professionals. Additional monitoring, of course, is going to be required for women who have got hypertension and diabetes. The Royal College of Obstetricians and Gynecologists have therefore advised that there should be no change at all. If there are going to be any changes, and that should be in the form of service modification. Again, this is just to reduce the risk of transmission. Women should be provided with facilities for monitoring themselves, particularly those who are going to be self-isolating or with confirmed COVID. Things like home-based blood pressure monitoring can be made available, provided that those, of course, been standardized and the women have been taught how to use them. The women should be provided with full care, basic assessments like urine blood pressure and the measurement of the size of the baby by the midwife should continue despite COVID. In some cases, virtual consultation is possible. I think do telephone appointments, video conferences where there is available, particularly during the time of lockdown. This is to make sure that these ladies are asked and assessed regarding their pregnancies. Where there is a combined in-person appointments, it is recommended that every blood test are done at the same time to minimize the risk of coming back and forth. For screening for diabetes, the college recommends that there should be absolutely no change. So the key messages, of course, from this is that antenatal care is still very essential, even despite COVID. Women should attend their clinic appointments as necessary, and where possible, virtual contact can be made for regular antenatal review, particularly by the consultants in patients with diabetes and hypertension. In some areas, one-stop clinics, if are available, that would be appropriate. And of course, encourage self-monitoring. And lastly, I think I was going to do this, but Peace has already dealt with it.
Yes.
So I think I will just rush through before we folic acid. So we're just going to rush through the complication and then we can finish the presentation. So in conclusion then, hypertension and diabetes in pregnancy, they still constitute very significant underlying medical conditions, increasing the risk of severe COVID. We have also seen that eclampsia is a serious complication of hypertension in pregnancy and a leading cause of maternal death. Women with diabetes still need to be cared for by a joint diabetic obstetric and team and nutritionist and specialist nurses to optimize the pregnancy outcome. Pre-pregnancy counseling, of course, is essential for both diabetes and hypertension. Aspirin, folic acid, vitamin D are strongly indicated in both diabetes and high blood pressure pregnancies. During the COVID pandemic, quality of care should not be compromised, and extra care needs to be given to pregnant women, particularly those who are of the BAME heritage, and in particular those with hypertension and diabetes. So I think that concludes this presentation on hypertension and diabetes and in medications.